minutes
This
later.
conference will now be recorded.
Okay. So let me show you the screen. Are you able to see the screen, everyone?
Yes.
Yes.
So first of all, congratulations to all those who have passed part 2, because that is a very, 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 like, it's a huge success, and that's a very big step in MRCOG, because part 2 is the elephant of MRCOG, and part 3 and part 1 are comparatively easier. Part 3 is more about communication, more about how you uh, have reflexes to the emergency situations, and how you tackle with the patient when you are the only one who is seeing the patient in emergency or in the clinic, right? So this is what you expect in the exam. You have 14 modules, same modules as of part 2. So you don't have to read any new syllabus. You have to read the same syllabus as that of part 2. But only you have to start applying your part 2 knowledge. That means how you do it when you have the same patient in front of you. Like you have a patient of recurrent miscarriage and you have read the guideline. So you should be knowing how to apply that to the patient, starting with all the 5 domains that we'll cover as the session goes ahead. Okay, so these are the cubicles that we all have when we have a physical exam. Nowadays, because of this lockdown, this things have changed with RCOG, and last time was a completely computer based exam. This time I spoke with some of the seniors in the morning today, and they said that maybe you'll have an option of either going for an online exam or for an offline exam. So it will be your choice, but they are not very sure with that. So they'll do that once they fix the examiners, and then they can go ahead with what exactly is going to be the seen during the exam, whether it is going to be a completely computer based exam or a completely physical exam, or on and off both, okay, based on the choice. So nonetheless, the things are not going to be different, because whether it is a computer based exam or a physical exam, your preparation is not going to change, right? So the syllabus is going to be the same. You'll be having 14 stations, out of which there will be simulated patient tasks. That means one person will be sitting in front of you, acting as a patient, and he or she will be telling you the symptoms, like in our OPDs, and you have to, you'll have a task. It will be written in front of you before you get into the cubicle. Even for the computer based exam, they'll give you 2 minutes time initially, and they'll give you the scenario, and you have to enact exactly in the same way, and manage the patient. The patient can make changes. A patient may have hidden agenda. The patient may sometimes even change the history for different students. So that can happen. So never go along with, like, sometimes what happens is our friends tell us that this is the station, but it may also change. Okay, so always react to how your role player is acting with you, because things have changed when we gave the exam. So the role player was saying different things to our different colleagues, and had different things to say to different colleagues. So he just changed one sentence and the whole thing changed. So always go according to your patient. Okay, so you'll be having, as I said, role player tasks, and there'll be some colleague tasks. That means you'll be having examiner sitting in front of you, and he'll be asking you questions, and you may have to answer exactly like that for that. Or there will be some labor ward prioritization and gynecology ward prioritization stations as well, where you'll be given 7 to 8 patients depending upon their wish. Mostly they give a huge list of patients, and you have to tell them how you'll manage the patients when you're in the labor ward, and you have 7 patients together. So which one is the emergency one, and how you'll manage that. Okay, we have done this all this in our residency, and we know how to do that. It is just the matter of communication and how to present there is what is going to be useful in this course. Okay. As I told you, there will be one examiner who will be testing your clinical knowledge. There will be another examiner who is a lay examiner. Not all the stations will be having lay examiner. So sometimes when we gave the exam, it was there were 4 stations who had lay examiners. They may change 1 or 2 stations. So you may have 3 to 4 lay examiners also, right? So the lay examiners only check how you communicate with the patient, whether you're able to empathize with the patient, whether the patient is comfortable with you as a doctor, and how as a doctor you're beneficial to the society, whether you're beneficial or not. So that is the only thing that the lay examiner is going to look at. Okay, so if you're good at that, it is always going to be a win-win station, a scoring station, right? So as I told you, you'll be getting 2 minutes outside the station, and where you'll get all the details of the patient. You have to make the diagnosis or the differential diagnosis in mind. You have to write down the important questions that you need to ask for information gathering, again, to make a differential diagnosis, right? And then you have to think of all the managements of different diagnoses that you're going to make, and you have to act accordingly in the station. Okay, so there, of course, because we have worked in gynecology wards, so we know how it is. So don't worry, we have passed part 2, so you have the knowledge. It is only how you reciprocate it in the station. So that we are going to help you with. Of course, you have to keep calm in those 2 minutes, because only then your mind works. Keeping your mind awake for 14 stations together is a very difficult task, and you need to have practice for that, right? 10 minutes inside the cubicle, as I told you, you have to introduce yourself. You have to start with open questions, and mostly then you have to start with the information gathering, accordingly come to the management, and help to decide what is good for the patient, right? So we offer the patient, right? That is what we have learned in Mrcog, is we don't advise the patient, we offer treatment to patient, right? So you will understand now why the guidelines have words like offering, recommendation, right? So these words are going to be useful in part 3, and how they are applied, you will understand this in part 3 now. Okay, so what things are important? Of course, all the things that were important for part 1, part 2, and to achieve your status at this point of time as a obstetrician gynecologist, the same thing. Only thing that is different from what we did for our exams was a study partner. For part 3, it is always better to have a study partner. In fact, you should always have a study partner, because uh, your study partner, you have to communicate with someone, so that you can't do alone. And of course, the study partner can't be with you all 24 hours. So you also have to know how to do things when you're alone, imagining that your role player is going to say all these things and how you're going to react. So you can do that in front of the mirror also. So when you don't have a study partner with you for some time in the day, and you are alone and you have time to study, then you can also do it in front of the mirror. So you can take help of your relatives, of your children, whoever is able to enact in the role player's way, or going to understand the station. And we have all tried this in fun way, and believe me, part 3 is not a very difficult exam. In fact, it can really turn out to be very uh, happy exam, or something which you can actually find time to spend with your family, because your family members can become your role players, and it becomes fun to give this exam, because then you know how to enact. You become good actors after you pass your part 3, and of course it makes a lot of difference in how you give management to your patient, and also makes difference in your own personality. You'll understand all of this when you pass your part 3. So these are the books for the exam. I have given almost all the books in the free group. if there are new things coming up, I'll also put that in the groups, and we are already taking free stations for you. Okay. So these are the books. If anyone doesn't have these books, all these books are important. All the stations are important, right? And these are the domains tested. That is information gathering. Then communication with patients and relatives, communication with colleagues, patient safety, and applied clinical knowledge. Modules are the same as part 2, right? Now we have our mentors here, Dr. Jia. Most of you know Dr. Jia because she is also a mentor for part 2. So she will tell you more about how to do information gathering and how to take history, because this is how you start your station, and most of your marks are gathered here only, because that is when the examiner decides whether to pass you or fail you, because nobody is going to listen to you for all the 10 minutes. So this is a very important part. Yes, Dr. Jia.
Hello, good evening. Yeah. Regarding information gathering, we know that history taking we are learning from our undergraduate days. So it is not a big problem for us. But here the limitation is we have less time. We have to take the relevant history. After that, we have to examine the patient. Then we have to, discuss regarding the investigation and the management plan also. So the common pitfalls are sometimes the student, the students will waste time by asking irrelevant questions, or maybe they are asking only closed questions. So the relevant history is not elicited. And maybe for me, I remember the examination was conducted in a big auditorium. So maybe some of the candidates are answering in a very loud voice, so it is a little bit disturbing for me in the beginning. So if you are not properly listening to the role player, sometimes you will not understand the answers, and you will keep on repeating the same question. That really gives a negative impression about you. And sometimes the actor will give you some clues, and you will ignore that also. These are the reasons when why you will fail in a information gathering domain. So and information gathering is like, it's a first, you will create your first impression in this. So you should be very good and fast, and you should take a relevant history. And we know the normal format of this information gathering. We have a little difference in the for the antenatal patients, for the obstetric patient, and for the gynecological cases. So depending upon anyway, you are getting 2 minutes to read outside. So in the mind, within that limited time, you should frame, or you can write down in that piece of paper they provide, that what all questions you are planning to ask in this domain. Okay, that will help you to go further. And in an obstetric patient, the LMP is very important, and the usual way you will ask the history of presenting complaint, and you should always ask a open-ended question, like how can I help you today, or could you please tell me more about your problem. So the patient, the role player will start giving you whatever the script is there. But what ultimate aim is, from the information gathering, we should come into few differential diagnosis. So few like negative questions you can ask the patient, like if you want to have rule out some differential diagnosis, you can ask some leading questions towards the end. Then in obstetric case, we will go with history of presenting complaint, then history of current pregnancy, regarding the pre-pregnancy, how she diagnosed the pregnancy, then how was the antenatal time so far, whether she had a dating scan, anomaly scan, GTT was done. Then in a chronological way, you can go through the past obstetric history. Then regarding gravida, para, these things are needed in the beginning itself. And the past obstetric history, mainly the mode of delivery, any miscarriages, ectopic, or the mode of delivery, all these things you will ask. And depending upon the case, the birth weight, the complications, anything in the antenatal, peripartum, or postpartum, breastfeeding, all these things you can go into detail. and past medical history, then drug history, especially any allergies, then family history, especially for fetal anomalies or any genetic condition. Then if it's a case of hypertension or diabetes, you can ask the history of similar things in the family. Twinning, you can ask the family history. Then social history is very relevant here, because you should ask the patient what is her occupation. Then is there any support at home? uh, then like her, whether she is a alcoholic, whether she is having a habit of smoking or using any recreational drugs. Sometimes you'll get patients like they will be having some domestic violence, hidden history will be there. So in that case, the patient will not be answering properly. So we have to ask leading questions like, uh, do you have enough support at home? uh, like you want to we should offer help also, like we are here to help you or support you, like that we have to offer. So these patients will like if the script is there, then they will open up. Unless we sometimes if we like, so the chronological order is important, because if you are not touching all the top, I mean headings, we will miss some important history. Then by the end you will you can ask like, do you want to add something more, so that if something we missed, the patient will explain at that time. Regarding the gynae history, almost similar, like history of presenting complaints and all, but sometimes we have to ask about the smear and contraception. And in gynae, we will not go into much details about the obstetric history, but sometimes it will come significant when if it's a case of recurrent miscarriage or infertility, or if it's a urogynecological problem, then the mode of delivery and all these things become significant. So depending upon each case, we have to ask the history. And this format, like if suppose if she is a postmenopausal lady, and there is no need to waste too much time in the menarche and all. So depending upon each domain, like each heading, and depending upon the case, you will take the history. Suppose if you have a case like you have a, simulated patient task with a colleague, like you have to teach her regarding like perineal tear repair or something, then here the information gathering, if it is a domain, then you have to ask, I just wanted to know why you are so much interested in this particular topic, and what exactly you want to do. No, so these questions should be asked, because in that station the information gathering will be like this. So depending upon each case, we have to go into details. Thank you.
Thank you, Jia. And yes, information gathering is very important for hidden agenda. As you correctly pointed out, that it is important for those patients who have had history of domestic violence or sexual assault. And believe me, if you don't touch that point, the role player will never open up. So it is really important to have a practice of all these kind of stations, and to practice with someone whom you don't know, so that you understand how the role player is going to enact. Right? Thank you,
One more
Jia.
thing I want to, yeah, one more thing I want to add, like you should always ask in a very simple language, and avoid jargons, and be very confident. And sometimes we have a I mean strict some headings will be there, but the patient is not responding in that particular way. So we should not show that hurry burry there. We should be patient, and we should allow patient to talk. We should not in our mind, maybe we'll be thinking, I have to finish my headings, so I have to take all these relevant topics. So if patient is taking time, we should wait patiently, and empathy and sympathy, everything should be there. So we should
Right,
not
right.
act that we are fast.
We should not finish the station. So that shouldn't be the goal. Our goal should be to tackle or to handle the patient's problem.
Yeah.
So that is what matters. Yes. And this is a very important point. Stop using jargons, because that is very common amongst medical students, we use jargons very much. So you should be knowing a layman term for every medical jargon, and that of course will teach you as we go through the course. Uh, we have another mentor, Dr. Sharyu. She has just joined Mrcog Gold and she is just passed out candidate. So she can give you a better version of how things are happening now with RCOG, and she will tell you on how to communicate with patients and relative and why this domain is important.
Hi everyone. Am I audible?
Yes.
Uh, yeah. So I will just touch upon the communication with patient and relatives domain. As you all know, this is a very important domain, and I think it will be tested in every station. Even if in sometimes if they have not mentioned it in the domains, it is something that all the candidates will be tested upon, and it will be through information gathering when you're explaining the condition to the patient, explaining the treatment. Through everything, the communication will form an important part. So I think the most important point here to have a good communication is to be stress-free at the time of the exam. Of course, it's very difficult, and the whole exam scenario is very stressful. But that can affect the way you're communicating, the way you're responding. So as far as possible, keep the stress levels low. When we start any station, an important part of communication skills is how you introduce yourself. So I would suggest that for all the stations, make a template for yourself about the introduction and the agenda. Because then once the start of the station is smooth, it builds up your confidence for the rest of the station. So introduction is important. We have these common lines like hi, I'm Dr. Sharayu, ST4 in the gynae clinic today. Something like that that you can say. And then, of course, you will confirm the name and age of the patient. And it's always important to make it clear what you will call the patient. So, as we say that, is it okay if I call you Mary, or how may I address you? This forms an important part of building a rapport with the patient. And then of course the agenda, wherein you'll make clear what can be expected from this consultation. Also, you can ask the patient about her expectations from this, so that you know what the role player is expecting. So the introduction and agenda will, if that goes smoothly, it will create a good rapport. After that, as Dr. Gia explained about the information gathering, um, again the communication becomes an important part of how you ask the questions, especially if you're asking something sensitive. Don't forget to signpost, like we say that is it okay if I ask you, some of my questions may sound a little intrusive, can I go ahead? It is important for forming an appropriate management plan, something like that. So signposting is very important in the information gathering when you're asking such questions. And yeah, so information gathering has already been touched upon. And after that will come the explaining the condition of the patient when you tell her what the diagnosis is and what it actually means. So while doing this, it is important to give her all the information in chunks. That is very important. Give tell her something maybe, and after some time always ask, are you understanding, am I clear, um, something like that. It actually helps the candidate, helps us also, because we get some time to formulate what we are going to say next. So always don't give too much information at a time. Always pause for some time, ask if she's okay, is it okay to continue, something like that. Another important part of communication would be showing empathy. So, in the course of all this, depending upon the station, if there's anything that is, that is sad, or if she's telling you something that is not right, then, saying something like, yes, I can understand, you're very upset about this, and I'm here to help you. So that empathy will not only come from what we are saying, but also from, the body language, which is important. And this comes from practice. When we practice more sessions, the empathy and the communication will be better. Also, things like maintaining a good eye contact with the role player, sitting erect and facing the patient, nodding in between. uh, you can say, whatever she says, you can just, as if it's a real situation, and you are responding to whatever she's saying. You can say, yes, I can understand, or just nodding your head is also okay. The non-verbal cues are also important. And something that is called as active listening, wherein you're taking cues from the patient. So as Dr. Preeti and Dr. Gia already spoke about this, that if it's a case of domestic violence, then she may communicate that to you through body language. She's not opening up, she's not giving you the right answers, but she's just fidgeting. And because all these role players are like, they're really good actors, so they will be able to communicate that through this non-verbal kind of communication. And so it is important to know what she's trying to tell you, so that you touch upon that factor, right? Then of course, breaking bad news is a very important part of communication. There will be at least one station wherein you have to give some bad news, and always keep a template ready for any such station, what you're going to say. So a common thing to say is, for example, Mary, I can see that you're alone here today. Would you want someone here with you? I'm afraid I have some difficult news for you today. Something like that. Any similar such thing you can. So, but it should be ready in your mind. If this station comes and you have to say this. And so not just saying, but the tone of your voice. So usually what they say is, you match the tone with the tone of the role player. That always helps. So if it's a sad situation, the role player will also give you that vibe. She will be low, she will be this thing. So you always match your tone with her. And of course, if the role player is crying, then always pause. Don't keep on talking when that is happening. Pause for some time, offer her tissues, offer her water. And you can, after this, it's important to say that, is it okay if I continue? Do you want to reschedule this consultation? Of course, she will not say that. She'll ask you to continue, but it's very important to ask her, take her permission if you can continue, right? Uh, then, of course, when you're explaining the condition, the diagnosis, avoiding jargons, which we have already spoken about. So, as Dr. Preeti said, that the jargons come very naturally to us. So, it's important to practice again and know what word we are going to use for some medical jargon always, because it can just slip out of the mouth while talking in the exam. So, that is important. Then, then when we come to explaining after explaining the diagnosis, when we come to the management options, we always give the options to the patient, that already Dr. Preeti said. And then of course the patient is going to make the decision. Our job is to give all the information, to give the pros and cons of each management option. And here our negotiating skills will also be tested in some in some stations, wherein the patient is adamant for going for some management plan which is actually not the best one. For example, someone with a previous LCS wants to have a home birth. Okay, so that will be a negotiating station. And here the communication skills become a little more important, because how you deal with that, right? So what we usually say is, when you're trying to negotiate first, so she has made it clear to you that she wants a home birth. First, always talk something positive about the home birth. So always talk something positive about what she has chosen, right? So you say that, of course, I can understand why you're choosing this, because these are the benefits of this. However, I would also like to tell you about some risks that are associated with this. So when you talk about the positive things, it's not like you're not antagonizing her right away, right? You're just telling her. So then give her what are the risks of that, and then come to the other option, which according to you is better. So then tell about the benefits of the other option, and then of course tell her to choose, and say that whatever you say, whatever you choose, we are here to support you, right? So that is for the negotiating station. And it is very important to be non-judgmental in whatever she says, whatever history she gives, or this thing. We do not have the role of judging the patient. So sometimes in our body language or in what we are saying, in our expression, that can come. So we have to make a conscious effort of not being judgmental, right? Um, then Yeah, so as I said, when we are giving the options and when she's choosing, the patient has the right to make the decision. It may be wrong according to the uh, according to the medical point of view, it may be wrong, but still it is her choice, and we have to support her. So we cannot even judge her for that. Um, and of course, at the end of it, you summarize everything, you summarize the treatment plan about how we are going to go ahead with this. And it is very important to check that she has understood everything. So we can end by saying that, is it clear? Is there anything else you would like to ask me? So that you are giving a final opportunity to the role player to ask you something. In case you have left out something, she will, she can give us a hint about what we need to touch. And the ending also, we can, have a fixed template in our mind. So of course we'll talk about the information leaflet. That's a very easy point and a scoring point. So we talk about we give her the information leaflet. In some cases, maybe some contact numbers which she can contact in case of an emergency. In some station support groups, that is important. And so we can end the station there. If we are admitting the patient, then we can just say that, I'm right here if you need anything. I'm giving you the information leaflet and I'm right here to, you can call me if you need anything. So we can end the station in that way so that it ends well. Um,
Right.
yeah, I think
Very
that's it from my
wonderful.
side.
Yes.
If I've left anything.
Wonderful. No, you have almost touched all the points. I was actually thinking of everything, but you covered everything, all the points by the
Okay.
end of your talk. Yes, and the very, very important point is communication is not about how you talk. It is
Yeah.
about the non-verbal. Yes,
Yeah,
communication also is
exactly.
very important. So how
Hmm.
you sit, how you look at the patient, and how you
Yeah.
offer help. Even there are some
Yeah.
props also kept. There is water. There are tissues. You have
Yeah.
to use that. So that is for a purpose. So it
Yes,
is
and I
not there
think this
for
becomes more important in the face-to-face examination, wherein
right.
your body language becomes very important. Yeah.
Yes. And that with all the stress, it is difficult to
Yeah,
have that
it's
confidence. So
very
you have to build
difficult.
that practice. You have to
Yes,
build that
exactly.
practice, of course. So going
Yeah.
ahead with our next, Varsha has joined because she did not until I started with the station. She's there. Anyone can tell me if she's there because I'll have to change the slide section to go back to the meeting.
I think she's not there. I'm not able to see her name here.
I don't
Okay,
think
so
she can.
I'll
I can't see her name.
okay. So I'll and Nusrat.
I can't see Nusrat's name
Nusrat
also.
is also not there. Hmm.
Okay, okay. So I can talk about this communication with colleagues, and any one of you can take up the next domain. So let me first finish that, and then we can talk about the next slide. Communication with colleagues. Of course, as I told you that there are going to be examiner stations wherein you'll be having the examiner sitting in front of you, and also uh, this this communication with colleagues is not only important about the examiner stations. It is also important about who you are going to call upon when you have an emergency. Like in fertility cases, you have to tell the patient that I'll be referring you to the fertility specialist. So there you score mark in communication with colleagues. So it is not only those stations, of course, those stations completely go for how you communicate with your seniors or examiners, or when you have the ST1 coming to you for teaching. Okay, so all these stations are specifically for communication with colleagues. But again, when you have role player stations, where you can score marks is when you refer the subfertility patient to a fertility specialist, or a postpartum depression patient to the perinatal mental health specialist. So when you pass, you know how to refer the patients to your colleagues, and you know when to communicate with them, when to communicate with your seniors, when you have examiners viva, and you have a patient who has got shoulder dystocia. You should be knowing when to call your senior. So when you speak about that, you have the chart, no, at the end of your guideline, and there it is written at what particular time you have to call your senior. So you should know why it is important. So that is how you apply your guideline. So when you say that at this point I'll call my senior, you get a mark there. Plus it also becomes important point of patient safety. So this is how all these domains are actually linked together, and you'll be seeing that every other mentor is talking about the previous slide also, because all these actually come together, and when all these domains are done very well, you pass the whole station. So this actually, it seems very easy, but it becomes easy only with practice. So once you start doing the station, it will feel difficult for some time, and sometimes it is like it is just communication. But believe me, it has to be practiced, and it has to be practiced in such a way that you can do it easily when you go for your stations. So that is the only way to go about it. And exactly as the slide is showing, you have to refer the patients, you have to know how to talk to juniors when you have ST1 coming to you in your teaching stations. You have to offer help if your colleague is going through some problem. There can be some bullying stations there, right? So where your, your junior is actually facing bullying, and that is why he or she is not able to work properly um, at the workplace. Then you have to offer help, and how you offer help, that is again important. That is tested in examination with colleagues. Again, when you have when you have your examiner's task, again how you greet your colleague and how you go about the station, again that is tested in your communication with colleagues part, right? So we have done teaching stations in a free group for like it has been done. Almost all the teaching stations are done, and if someone of you doesn't know how to go about it, please scroll up in the Telegram group, because almost all the stations from the teaching part are done, and this is a very important, very scoring station, and very scoring domain, because you just have to remember few points in communication with colleagues. You have to refer the patient, you have to uh, tell about pulse, all these things. They become important, and you score very high if you just talk about all these things. If you are empathetic with your colleague, things become very easy. If you uh, give them some leaflets, or give them some some areas to read upon, some articles to read upon, and offer help in case of difficulties, things become very easy, and it becomes very scoring. So there is not much to talk about communication with colleagues. It will come as we go through the station. We'll go ahead with the next slide, applied clinical knowledge. So Dr. Rupali, you take over this slide and the next one also.
Hello friends, it's been very nice to listen to all of you, and most of the topics are really well covered by now, the domains. What I need to say is, amongst all the domains, I thank Dr. Preeti to give me to speak on patient safety, and now she has put this applied clinical knowledge on me. Okay, so amongst
Yes,
all
you
the
can do
domains,
that.
yeah,
You're very prompt, so I know that you can easily cover this.
yeah, I'll just try. So, amongst all the domains, what I feel is the most difficult is patient safety. first and applied clinical knowledge. I'll tell you all why. See, information gathering is something which we all know what, even if we don't know something, we are definitely going to ask something and gather our points. So far as communication is concerned, that is one skill which we have to learn. But if you miss out on applied clinical knowledge and patient safety points, then you lose the station. That is what I want to tell you, because that's the reason why whenever you're practicing stations, for every station, I want you all to make a patient safety column and write there the patient safety and applied clinical knowledge. Mention those points, like what is it which is going to be stressed upon and what are you going to speak on applied clinical knowledge. Now, after giving your part 2 exam, we all know that all of you have been really, really good in your knowledge. And this knowledge you have acquired by reading the GTGs, the NICE, the TOG articles, the strategy, the PIS, everything. Now onwards, whenever you're practicing for your part 3 exam, whenever you pick up a topic, say like heavy menstrual bleeding, read the patient information leaflet simultaneously. So what you will understand is what out of the entire applied clinical knowledge, what is it that you need to speak on? Okay. In patient safety also, what is it which the patient, you need to inform the patient so that the patient will be safe? That's very important. Second thing in applied clinical knowledge is you don't need, now for your part 3, you do not need to read your NICE guidelines, you do not read to read your GTGs or XYZ. Do not waste time. This exam is a technique based exam. This exam has less of efforts so far as reading is concerned, and it has more of efforts which you need to put in by means of finding a study partner, giving at least 2 to 3 hours with the study partner, and expressing yourself, speaking up, because here you will be bombarded with questions from the role player. So you should be used to talking those questions out. Now, for example, in applied clinical knowledge, I'll give you an example. Like if a patient who's got a fourth degree perineal tear and she comes to you and she's confused, what is she going to, what is her mode of delivery going to be? You know that what is the best mode of delivery for her, but you have to offer, just like what Dr. Preeti said, you have to offer all the treatments for her. You cannot just tell her cesarean is good or a normal delivery is fine. Whenever you're telling her or whenever you're offering her, explain to her why do you think that would be the best, but yes, you can also think about this option, and then go to explain the risks and complications. Now, if a patient who has got a fourth degree perineal tear and who has had no bowel complications, nothing at all, and she's all fine, and previously she has had an instrumental delivery, and if she asks you, doctor, will you give an episiotomy, what would be your answer? The evidence says that episiotomy is not required. So you may go for a normal delivery. In case you opt for a cesarean section, then the risks and complications are so and so. And then you show your applied knowledge by telling her what all the risks and complications of a cesarean section is. And then lead the patient to the treatment which you think would be the best for the patient. Okay? So this is so far as applied clinical knowledge is concerned. In applied knowledge, you have to also remember the dosages many a times, like which medicines are to be used, where, and like in herpes, you should know acyclovir is to be used, but acyclovir can be used after 20 weeks. That is something which you need to remember. And then the dosages which are needed to be remembered. So these are very important stations, and make one diary where you can mention and remember this, so that at the end, when you have just 2 weeks for your exam to go, that is the time you can rehearse and go through this. In applied clinical knowledge, I think these are most of the topics which I think need to be covered. Now, so far as patient safety is concerned, it's a very important domain, and believe me, it will be assessed in all the 14 stations. Whenever a station comes in front of, whenever we face a task, we know what to gather, we know what information to gather, we know how to communicate, we know the applied knowledge, but sometimes we just blank out what is the patient's safety, what the examiner is looking out for. And that is precisely the reason, whenever you're doing any task from today onwards, make a template, as Dr. Sharayu said, and write down the patient safety point in this. Now I'll explain to you what points and how you will write down. I'll give you examples so that when you give examples, you remember it faster. Now, suppose a 31 weeks patient who's a primey who comes in preterm labor. You start tocolysis for her, but in 4 to 5 hours she becomes full dilated. What is it? What you're going to say? Like the examiner is looking out for that one word. You will say everything. I will give this. I will do that. I will ta ta ta. But if you do not say stop tocolysis, you lose out a point on patient safety. Sometimes we just assume that, obviously we are going to stop tocolysis, but no, the examiner wants us to say that stop tocolysis. The moment you say I will stop tocolysis, they will give you the two marks for your patient safety. Okay. Now similarly, in case of enhanced recovery program, what is most important in patient safety is we have to pre-op optimization of the patient. Like if the patient is a hypertensive, if the patient is a diabetic, if the patient's BMI is more, we have to optimize all these things, make the references, and bring down the BP, bring down the sugars, do the weight control, exercise, and then post the patient for the procedure. That is called patient safety so far as your enhanced recovery program is concerned. Now, a patient is walking in for a pessary. If you miss out on asking the patient whether she has a latex allergy, you miss out on your patient safety point. This is a point from information gathering. You're gathering information, but you're also being marked for patient safety, and that is something which you have to remember. Then, for any patient is supposed to be posted for surgery, and the patient is having latex allergy. What is the safety point? The safety point would be when you speak and tell the examiner that I would be posting this patient first on the OT list because, and I will be informing the OT staff and all the theater staff that my patient is having a latex allergy. Okay, so this is your safety point that you have informed everyone around and you're posting the patient first. Then, if the patient's BMI is very high, then in these cases, you cannot forget about the VT prophylaxis. Then in lab also the route of entry becomes very important in such patients. The patient is having some previous surgeries on the abdomen, then you have to speak that I would think about an alternative entry point. Okay. Then so far as drugs are concerned in patient safety, now drugs you have to know all the most of the side effects are the important side effects, the interactions, the dosages, which trimester which drug can be given. For example, if a patient of who's pregnant and comes to you with a UTI at say 37 weeks of pregnancy, you cannot give her nitrofurantoin. But you, if she comes after 3 months and before 36 weeks, yes, you can give her nitrofurantoin. So this is here is the patient safety. Why we do not give nitrofurantoin in the last 3 weeks? Because it can lead to neonatal hemolysis. So this point is something which you have to remember. Then in case of suppose a patient comes with herpes in pregnancy. Now in this case, if you because of your knowledge, you will be explaining everything. You'll gather the information, you will give applied knowledge, you'll tell the acyclovir or dosages, everything. But if you forget to mention that I will refer this patient to the gum clinic, this is a very important safety point, the genitourinary medicine clinic. This is communication with colleagues. But here, this point is also included in the patient safety. So here you will miss out on the point if you do not mention the gum clinic. Similarly, when we are taking the gynac pre-op or the post-op rounds, you have to mention that hand washing in between all the patients. Whenever you're shifting bed from one bed to the other, you have to do the hand washing or use the sanitizers. In case of emergency, say like patient has walked in and you decide to give a painkiller, so you will be saying, yes, I would like to give a painkiller to the patient, but you have to mention and say that, of course, after ruling out if the patient is having any allergies. Okay, so these are the few points, and one or two points more is like so far as all antenatal patients are concerned, most of them you'll have to ask, not most, almost all the patients you'll have to ask about the Jehovah's Witness, because all antenatal patients, if they may land up with a PPH, they may land up with abruptions. And so knowing that whether they are Jehovah's Witness and what preferences they have for cell salvage, etc., needs to be asked. And that is a very important patient safety point. And in the onco section, for the patient of suspected cancer, the 2 week wait pathway is something which you have to remember. That will also tell us that you are thinking about the patient here. So these are most, so there are every case, like, whenever we'll be taking up the courses, for every station which we will cover, we will be telling you what are the patient safety point, so that you will not miss out on those points. And this will help you in gaining the confidence when you're speaking with your patients. So this is most of, I think I've covered most of the topics. And in safety, you have to be able to demonstrate your ability to work under pressure and yet maintain the principles of safety. That is what this exam is all about. Every time you cannot say, I will ask my consultant, I will ask my consultant. No, you have to know that as an ST5, ST4, what are your limitations, what you can do, and when you need to call the consultant. Something like, if a patient is in cardiac arrest, in a pregnant patient, you have to give the basic life support and then say that I'll call my consultant. But as soon as a cardiac arrest patient comes, you say I'm going to call my consultant. No, you lose your marks. You have to say what basic life support is done till the arrest team arrives. So this is where you have to give your knowledge about patient safety. Okay, so this is all about patient safety. I hope that's helpful.
Yes, of course, it was very helpful. And I actually had nostalgia. I went through all the stations in my exam, and believe me, it is not a very good thing, because you have all the chills and butterflies in your stomach just before the exam. But as you correctly said, with the practice, and when we tell you that these are the patient safety points, when we take your course, we tell you all the important things to remember and make you understand how to go about different stations. There will be new stations also, one or two new stations. Most of them are recalls. In the last few exams, we have seen that they are repeating the stations, but you'll also get new stations, and you should also know how to react and how to tackle the new stations. And all this will come only with practice, only by going through new stations every now and then. So this is our part 3 batch, which we are going to start from the 1st of September. And you all can contact me, or Dr. Rupali has also put in her number in the free Telegram group. So if you want to contact, you can contact any one of us actually. All the mentors are very supportive, and believe me, I'm so happy to tell you. And I'm also really happy to listen to all these mentors, because I felt so proud of myself that I have got such a good team. Dr. Jia, Dr. Varsha, and Dr. Nusrat, everybody from part 2, they know both of them, all three of them, and everybody knows how good teachers they are, right? But uh, Dr. Shariu, Dr. Rupali, all of them are good scorers. They are very high scorers from the exam, from part 3 exam, and believe me, you're going to get benefited, like too much benefited, and you are going to pass in your very first attempt. I could sense that when I heard all of them talk about these slides, because I could see that they know how to cover everything from the station, and I don't remember any single point that was left in any of the domains. Believe me, anyone who did not have any idea about part 3, I think they have given you stations, they have given you how it is done, and they have told you so many important points, which I don't think they are even talked about in the courses which I attended when I went for part 3. So there are many points which were very new to me also. So I believe that we have a good team of mentors. If any one of you wants to join the course, please do it as early as possible, because then because part 3 is not like part 1 and part 2. We cannot have a group, and we cannot keep on adding people later on, right? So we can make uh, a proper group where we can put stations according to the candidates, and we understand where the candidates are lagging in, and we can make the stations exactly where the students need help according to the candidates. So it can be a personalized, a customized course for all of you. So please help us to help you. And in case, as I told you, I'll be putting my number again in the Telegram group. So contact me or Dr. Rupali or any of the mentors for the course. I'll give you the fees details when you WhatsApp me or send me a private message. But believe me, it is going to be quite less than the other courses. And the reason why MRCOG goal has come up is because I remember how difficult it was for me to join these courses from outside India, and they were like too heavily priced. And giving a 50,000 exam, being an Indian, and being someone who has just passed residency or who is just into practice, to build up that money also becomes difficult sometimes, right? So don't get pressurized. This is the most economical course, and it is economical not because uh, we give anything less. It is because we consider that the candidates are not our students. We know all of you are our colleagues, and we have to be with each other throughout our lives. So this is not for commercial reasons. It is just to help you pass part 3, right? Um, this video is also going to be there on YouTube, on the YouTube channel MRCOG Goal. So if any one of you has lost some portion of it, you can go to the YouTube channel and you can watch this video again. Okay, so don't worry if you have not attended some part of it. I'll also put the link in all the groups as well as on the Facebook groups. So anyone who was not able to attend this session also will be able to listen to this session afterwards. So hope this has helped you. If any one of you has any doubts, please ask now, because all the mentors are available here and they can answer your question. The last 5 minutes. Anyone has any problem? Parul, you're okay now because you have just recently passed part 2 and you have got an idea of how things are there now in part 3, because you're very new to part 3, right? Parul? I don't think so. She's here. Maybe she's not here, but I hope, yeah, I hope that this has helped you. Anyone has any doubt, please ask. Otherwise, let us end this session for now, and you can keep on asking your doubts on the groups, or you can directly message any one of the candidates or of the mentors, and we are happy to help you.
Yes, we'll be shortly also wanting to tell that shortly we will be putting also small videos like Shara, you and I are working on that. So like for information gathering, how would you go about? So you will get to see the expressions also and the non-verbal communication as well. On most of the domains, we'll be putting short videos like say, 2 minutes. These videos will also help you all.
Yes, so we are working on all the domains actually. The video section, the audio section, and the model answer question, like in the writing section, all the types, whoever likes whichever types, so that it helps all the candidates in all the ways. So hopefully this batch is going to be a successful batch, 100% successful batch. And given your details, if you want to join the course in like within next 7 days, so that by 1st of September, the whole of the course is prepared according to you. Okay, so signing off, all of us. Thank you, all the mentors. Thank you
Thank
once
you.
again.
Thank you,
Because
Preeti. Thank you.
Thank you.
okay, good night, then everybody. Good
Bye.
night.
Good night.
Good night.